Hi there. This is another segment of the gout background, which will be helpful for all the nurses working with patients in the TRUST trial. And I'm going to start with lifestyle considerations for gout, part one. And it'll take about 20 minutes to get through this. And then we'll have a part two, which is kind of a further exploration of some dietary factors. So let's start with part one. And long-term goals of therapy in patients with established gout is obviously to prevent recurrent gout flares and disease progression. And this includes a lot of lifestyle modification when appropriate, such as non-pharmacologic modifications, avoidance of flare triggers, and risk reduction. And that's kind of an overview of what you're going to hear about in the next two segments that we go through. So management principles. During the period after a flare, the following issues relevant to prevention of gout flares and disease progression should be addressed with the patient. And that's what you'll do in the TRUST educational sessions that you have with patients. Patient education should focus on the basis of symptoms related to gout, factors likely to provoke gout flares or disease progression, and the rationale for each component of the recommended therapeutic plan and the benefits and potential harms of each of these components. So just as you would do as a good clinician, talking about disease process, talking about treatments, talking about prognosis, we want to talk about the reversible causes of an elevated uric acid, hyperuricemia, which should be identified to facilitate some of the lifestyle modifications and other changes that may be helpful in risk reduction. And we'll talk about details. Management of comorbid diseases. And we've mentioned this before in other talks, but gout is common in patients with hypertension, chronic renal disease, and other aspects of the metabolic syndrome. And these are all risk factors for gout. And it's likely that better management of these can help to improve the course of gout. Some other management principles to think about is that thorough patient education is essential. It's very important for successful adherence to lifestyle and dietary change, as well as medications. And deferring detailed education until after a flare, rather than during a flare, is likely better for patient receptivity. So while a patient's flaring, you want to manage the flare and then make sure that they come back soon thereafter, the next visit in the TRUST trial, to discuss some of the principles, to reinforce some of the principles that you've likely introduced previously. It's also important that the clinician gets to know the patient so that the treatment program can be individualized. All of the patients in the TRUST trial are going to be on a similar algorithm, but obviously discussing and reinforcing is a very personal factor that your relationship with the patient is going to be critical to getting them to be more adherent with what we propose in TRUST. Risk reduction measures are numerous, and obviously hyperuricemia is necessary, but often it doesn't cause gout. Most patients with hyperuricemia never get gout. Hyperuricemia has several precursors, such as genetic mutations that might cause underexcretion of uric acid, usually in the urine, or overproduction. And those likely make up about 50 to 60% of the risk of getting gout, the genetic factors, and those are non-modifiable. We also know that there's many modifiable factors that can be impacted for risk reduction. And again, we'll talk about those over the next 20 or 30 minutes. It's important that clinicians don't blame patients for their gout. there's been a bias that patients with gout are, heavy drinkers and not taking care of themselves. And it is true that these dietary and lifestyle factors are important, but as I said, 50% of the risk of gout is from genetics. So patients cannot modify that. There's a lot of stigma attached to gout, and we really don't want to play into that stigma. We want to reduce stigma so patients are more receptive to the recommendations that we make as part of the TRUST trial. So let's talk about risk reduction strategy 1, treatments of comorbidities and concomitant medications. And I've mentioned this several times, but to mention again, hyperuricemia and gout are frequently accompanied by one or more major disorders such as hypertension, obesity, diabetes, hyperlipidemia. Often we think of about those as the metabolic syndrome or aspects that are manifest because of insulin resistance. We know cardiovascular disease associates with gout, chronic renal impairment, and other certain dietary factors that we'll get into in more detail. These associations raise questions of whether lifestyle or pharmacologic strategies treating those comorbidities may reduce the risk of incident gout. And that's something that we're looking at within the context of TRUST. But we also know that gout might contribute to some of the adverse outcomes for some of these comorbidities. Weight reduction towards ideal body weight and moderation in ethanol consumption have each been convincingly shown to reduce the risk of incident gout and the expression of established gout. So again, this gets to this concept of we can reduce the risk through chronic factors as well as some triggering factors, and we'll talk more about those. So managing these common comorbid diseases is important, and we want, as part of TRUST, we're not here to manage the comorbid diseases, but we want patients to understand the context that gout is part of a whole web of different metabolic conditions. And so managing the diabetes and managing the hypertension and managing the obesity are really part of managing gout. Again, reducing towards ideal body weight is important, changes in dietary composition. I'll talk more about that. Reductions in alcohol intake, because alcohol probably is an important trigger for many patients. And we know that reductions in alcohol can reduce serum urate, probably by a little bit, but every little bit counts. Substituting where appropriate and safe to do so, medications that may be less triggering can be useful. But sometimes this is really outside of what we're doing within TRUST. We're not going to change the diuretics. We're not going to change low-dose aspirin, which is cardiovascular risk reduction, but we want to be aware of those factors and also educate patients about those factors. Again, low-dose aspirin, which is commonly used for cardiovascular risk reduction, may increase serum urate. So it can be a trigger in some patients. Other concomitant medications that we think about are diuretics, which are commonly used for hypertension or essential hypertension. And diuretics are important as a risk factor or triggering factor for gout because of how they reduce blood volume and therefore increase saturation of uric acid, leading to its crystallization and attacks or gout flares. Hypertension sometimes can be controlled by another agent, but we also need to think about their overall primary care regimen. We're not in the business in TRUST of changing around people's medications for hypertension, but we want to be aware of them. And sometimes it may be appropriate to have a conversation with the primary care physician, but never encouraging the patient to stop a diuretic, because diuretics are very useful for hypertension, which we know is an important condition to control. It is interesting that the angiotensin receptor blocker, losartan, has uricosuric effects, lowers the uric acid by excretion of uric acid in the urine. And so it actually can be a good alternative agent for some patients who are having recurrent gout flares. And that's something that The investigators, the clinicians involved in trust, can talk with the primary care doctor if a patient can't control their flares by other means. Again, hypertension and diuretics are important in the whole milieu of gout, and so we think about other medications, like I mentioned, losartan, hydrochlorothiazide. But this is not really what we're focused on in trust. It's just something that we think it's important for you as clinicians taking care of these patients to be aware of. As I mentioned, low-dose aspirin can actually reduce the excretion of uric acid, and so it can raise serum urate. But we know low-dose aspirin, typically 75 to 325 milligrams per day, can be very important for certain patients who have known cardiovascular disease, a history of cardiovascular events, etc. So this is something that we're not in the business of suggesting discontinuing, but we just want patients to be aware that the low-dose aspirin can be exacerbating issues. So that was risk reduction strategy 1, comorbidities and co-medications. And now I want to turn our attention to obesity and diet. And that's what we're going to spend most of the rest of the time discussing. So we know that patients who are overweight are more likely to develop gout. And obviously a healthy diet aimed at achieving weight reduction. Some people use the target of 3 to 5 pounds per month. I often say if you can lose a pound per week, that's a great goal over time, and often it can be maintained. And that can be through reduction in calories, increase in caloric expenditure through exercise, or sometimes through medications. But we need to make sure that there's adequate protein intake, usually through low-fat dairy or plant sources. Sometimes replacement of simple sugars with complex carbohydrates can be useful, and decreasing saturated fats. So patients need to be educated about dietary modifications that can be helpful, and that these may be part of the reason why patients are predisposed towards gout. Patients should also be informed about minimizing or avoiding frequent consumption of alcohol-containing beverages, beer, wine, spirits, and sugar-sweetened juices or beverages containing high fructose corn syrup. These are both known to be triggers for some patients. As well, it can raise the serum urate. We know that increased adiposity and weight gain are risk factors for incident gout. Weight loss has been shown to be beneficial in reducing serum urate and gout symptoms in patients with established gout, like we'll have in trust. Beyond weight loss, avoiding potential triggers, as we've mentioned, and every patient with gout often can identify their triggers. Shellfish, some patients of mine like liver. They like organ meats. They like a heavy, steak dinner, and that brings out a gout attack. So patients often can identify these, and it's very useful in your visits with patients to talk about what are their triggers and how they can avoid them, and then keeping track of them sometimes through a diary, etc. Obviously, patients with established gout, and all patients, should participate in exercise appropriate to age and comorbidity status. And I think optimizing overall health and weight is always a goal. Diet had been shown in different studies, and here we're just mentioning a few, but there's many studies. This is a health professionals follow-up study with 47,000 men with no history of gout. The risk of incident gout was higher in men with higher BMI. The magnitude of the association became larger with higher BMIs, and men who gained weight during the health professionals follow-up study had a increased risk of incident gout. Profound weight loss in patients who undergo bariatric surgery for severe obesity has been associated with an improvement in in incident gout. So reduced risk of incident gout in patients who undergo bariatric surgery. Again, we're not in the business in TRUST of suggesting bariatric surgery. All the patients in TRUST have established gout, but we know these are data that support our recommendations for reducing weight. And then a meta-analysis published in the last several years showed that in patients who undergo bariatric surgery, that there are serum urate reductions that are seen relatively early. Again, we're not recommending bariatric surgery, but this should give you a lot of confidence in the recommendations around weight loss. We know that dietary composition can influence serum urate levels, and again, specific foods sometimes serve as triggers. So with that, I'm going to wrap up this first phase of this discussion on lifestyle and obesity, and then we'll return again to the second phase, talking about specific dietary factors, specific aspects of alcohol use as triggers or predisposing factors. So thank you for your attention.